Good afternoon. Welcome to Remaking the Economy, Health, Racial Disparities, and Economic Justice. I am Steve Dubb, Senior Editor and Director of our Economic Justice Program here at Nonprofit Quarterly, coming to you from Boston on land historically stewarded by the Massachusetts Nation. This webinar builds on a collection of articles on healthcare and the economy published in this quarter's Nonprofit Quarterly magazine. To build on those articles and discuss these issues here, our expert panelists today are Ben Palmquist, is a Program Director of Healthcare and Economic Democracy for Partners for Dignity and Rights, a New York City-based nonprofit. Al Richmond, based in Raleigh, North Carolina, is Executive Director of Community Campus Partnerships for Health. And Dr. Yolandra Toya is a physician and community pediatrician practicing in New Mexico and a citizen of the Jicarilla Apache Nation. A few notes. First, we are very excited to take your questions. Other than the title slides, this webinar has no slides. We will begin with a set of prepared questions and then get to your questions in the second half hour. Please enter questions into the question box at the bottom of your screen, and I will share as many of them with our panelists as I can. Second, we always get the question, will I get a recording of this webinar? And the answer is yes, you will. It should go out to you by email by Monday. So no need to put questions in the chat about that. One last thing, this webinar is free, but producing it is not. So if you like what you see and can afford to support MPQ's economic justice work, please consider making a donation today. We also encourage you to contribute through your participation by joining the conversation in social media with our hashtag, hashtag #RebuildTheEconomy. Thanks so much for joining us. And there'll be a survey at the end of the webinar to inform our work, so please complete that. And with that, we'll begin. And I want to start with Ben, if you could, Ben Palmquist, if you could introduce yourself and talk about, what are some of the structural causes of healthcare injustice in the U.S. and what can we do to address some of them?
Thanks, Steve. Thank you for having me, and hi, everyone. It's good to be here. I just want to start out saying, I promise this won't all be doom and gloom. I actually am hopeful about a number of possibilities before us, but I do think in this moment we're all in, it is really worth looking clear-eyed at just how many people are suffering. And so just this week, we reached the point where 400,000 people have been killed in this country by COVID-19. So it's killed by the virus, but also really killed by the failures of our institutions to protect us. And that, 400,000 is massive. It's the equivalent of the entire city of Cleveland or Minneapolis or New Orleans being killed within the space of a year. And so we're in this staggering health crisis, which of course is also an economic crisis and also a racial justice crisis. And so it's a really heavy time. And this, is coming on top of 30 million people uninsured every year, even more than that who are underinsured because although they nominally have insurance coverage, can't actually afford to go to the doctor still, or are pushed into mountains of debt. And so there's just these layers and layers of things that people are struggling with. And as we'll be talking about today, the pains aren't all felt equally. So there's a lot of inequities that mean that the way it shows up is, in a lot of cities, a lot of states, they're just very different life outcomes and health outcomes for people. So that Black folks and brown folks on one side of town often have life expectancies 10 to 15 years less than white folks, wealthier folks on the other side of town. But why, right? What are the structural underpinnings of this? And we know all the problems. One of the most infuriating things to me is that all of these injustices we're dealing with are really they're not natural, they're not inevitable, they're the result of political decisions. And so the United States has chosen to leave people uninsured and insecure, chosen to privatize and to commodify huge swaths of health insurance and healthcare delivery. The U.S. has chosen to maintain unequal and exclusionary access to care and chosen to treat things like injury, illness, and disability as individual responsibilities and individual burdens, rather than as mutual needs that we share and collective responsibilities that we hold to one another. And I think there's really sort of three interwoven structural forces at work here that all work together: private profit, private power, and racism. And so I'm just going to talk briefly about how these work. So private profit is really the notion that the healthcare system should function to deliver private wealth rather than human health, right? So I would say that is completely backwards set of principles guiding the way the healthcare system is oriented. And in an unequal society, when our ability to get care is predicated on whether we have money to pay, that inevitably excludes huge swaths of the country from getting the care they need. Profit, of course, is also wrapped up in power. So there's really unequal distributions of power throughout the healthcare system. And this affects us on both an individual and a collective level. So as individuals, we're completely disempowered in many of our healthcare decisions. So we don't have total ability to decide what medicines or treatments we'll get because we are often not covered, we can't afford them. And healthcare workers, doctors, nurses, and others are disempowered in their work as well. And so as individuals in these systems, it can be really painful and alienating. And collectively, we've really been stripped of the ability to come together and decide what kind of a healthcare system do we want? What values should guide our healthcare system? Where should we be steering our shared resources? What kinds of medicines should be researching? Who should be setting healthcare prices, and what should those prices be? And especially in communities that have been historically and continue to be really subjugated, who should be making decisions about what form healthcare delivery looks like in Black neighborhoods, on Indian reservations, for LGBTQ people, and for other folks? And so the third piece is really, I think, that the linchpin that enables this private profiteering and private concentration of power, which is this sort of acceptance of racial ideology, which is the notion that there are fundamentally different groups of people, and that some people are inherently more deserving than others. Now, this isn't just about race, right? Class, gender, sexuality, immigration status, disability, all these things interweave and interact in how we experience the world. But in American politics, racial ideology has really been the primary tool that has been weaponized and to put some people above others. And that serves to justify these systems of private profiteering and private power, because it's what tells us that some people are not entirely deserving of adequate health care. And of course, this is brutal to Black folks, to Native folks, to working class immigrants, and other racialized people. But it's also, I would argue, really brutal to white people, and really, really brutal to sort of just our collective ability to come together in order to affirm that, yes, we all deserve healthcare, we all have a fundamental right to care, and we have a responsibility to one another to make sure that we can all get the care we need.
Thanks, Ben, and thanks for grounding this in 400,000 lives lost with COVID. That's a death toll that's equal to the number of U.S. soldiers that perished in World War II. So appreciate that. Al, could you introduce yourself and talk about Community Campus Partnership for Health? What does good community-based health research look like? What have been some of the challenges? And I got a question here from the audience that it seems like maybe you can weave in and talk a little bit about what are the social determinants of health, just to sort of set that.
Yeah, sure. Thank you. Steve, thank you for inviting me to be part of this discussion today. I think it's really special. We, in many ways, believe that today or yesterday certainly represented the dawn of a new era, we hope, in the U.S. and how we look at health care, the healthcare delivery system, and health access as well. I want to just pick up on one theme that been lifted up, and that is that of racism, the importance and the need to actually name racism as really a public health crisis in America. Where we are today is no accident. It is about a system that has been very much racialized since the inception of this nation, and efforts to continue to marginalize individuals based on how people present, and some ideologies around superiority and supremacy, inferiority as well. And so I think it's critically important to acknowledge that and to just continue to lift that up. Unless we name racism, we are tempted to actually forget its impact on the public health system. So when we think about community-based health research, this is a topic that's important in community campus partnerships for health. I mean, our role is that of, for the past almost 25 years, of building partnerships, what we call authentic partnerships between academic institutions and the community to work together to address some of our most wicked health problems and issues. We define health very broadly, not just being physical, but what the World Health Organization talks about in terms of not just being free of disease, but it's really about a number of factors in terms of our physical, mental, spiritual, emotional health as well. So for me, good community-based public health is really about centering the community and the approaches and practices of health research and health science and health discovery. One definition that I really like when we think about community engagement, moving from who is the community, but to how do we engage those people, is that it's a process of working collaboratively with and through groups of people, affiliated by geographic proximity, special interest, or similar situations to address issues affecting the well-being of those people. The operative word being proximity. And so sometimes when we think about community and specifically community engagement, we think about people living in a very well-defined geographic space, but it's broader than that, in that it can include other individuals living outside of a geographic region, but have a proximity or closeness to the issue, not just those living with the disease or that present some type of a phenotype. It's about the individual, it's about the community, it's about the institutions in that community as well. Recently, one of my colleagues shared with me this, I think, a powerful statement, and that is that no one is an expert in my life experiences but me. And so when it comes to community and community engagement, it's critically important that we center the voices of those who have been impacted and are living with these issues every single day, and not assuming that because of where we sit in a kind of a racialized hierarchy or gender hierarchy that we know best for them. I think that the idea of translating into the work of really engaging the community and translating this work out in a way that it really has an impact, a positive impact on the community. I want to lift up one exemplar, and that is the work of the Patient-Centered Outcomes Research Institute, PCORI. I believe that PCORI is an example of centering what we call the patient community in the work. So there are some examples of this that are out there that we can kind of look at as how we do this. So for a number of years, the U.S. government was engaged from 1932 to act in 1972 in the U.S. Public Health Services research project on the effects of untreated syphilis in Black men in Macon County, Alabama. Many of us call that the Tuskegee study, but it has that simple name to actually does a disservice because it doesn't recognize the culpability of the U.S. government in that work. But the impact of that study and on the community there and broadly is oftentimes kind of lifted up as being this kind of seminal example of what went wrong, and that now we are doing much better in healthcare and health research. But I think it's important for people to understand that it's not just about what happened at Tuskegee, but it's what happens. It's about what happens every single day when individuals interact and interface with the healthcare research system and medical research system. It's my experiences this morning, my experiences this afternoon, And so we can't exclude people from research as we've done in the past, and then kind of in an emergency basis, kind of rush in and just say, oh, yeah, we want you to be involved in research. The engagement or good community engagement is about building upon relationships. And that takes a lot of time. If we kind of revert back to some really bad behaviors, we then see the community and community engagement is really about research subjects and not research participants. And such that means that people are there when we need them. When we don't need them, we just kind of put them on the side. And I think finally, it's really about asking me and people in my community to be engaged in research. If you never ask, then it certainly doesn't give me the opportunity to opt in or to opt out. And so when it comes to social determinants of health, also, Steve, you mentioned that as well, is that it's really about the issues about where people live, work, and play and pray. It's all of those things. It's about the built environment. It's about employment. It's about education. It's about jobs. It's all of that. It's what we think about in terms of those issues that are under the surface. It's not just what a person looks like, but it's those other things that influence them. Education, employment, jobs, all of those things really do include social determinants of health. Social determinants of health are not just discrete services, but they're really about a constellation of factors that really do influence and impact all of our lives.
Thanks, Sal. Really appreciate that. Dr. Toya, I want to get you in the conversation, and I have a feeling you may want to add to that discussion and the stuff that Al said. Certainly introduce yourself and your work, and how do you apply these principles?
Well, thank you for having me. So I'm sort of the odd person out because I feel like I don't do a lot of work in nonprofit, but I think there's things that I can add. So sort of explore what our Native communities are looking like, and especially how COVID has affected our communities. I'm a Jicarilla Apache. I'm from northern New Mexico. I'm a pediatrician. I work in private practice. I'm sorry, Ben, but I do. I'm in one of those groups where it is for profit, but I'm okay with that. That's sort of what, that was sort of the career path that I took, but I also remain committed to working in the Native American communities. And for the past 6 years, I was a consultant at a tribally run clinic here in New Mexico at Jemez Pueblo. And most of what I did there was to address behavioral needs in children that were being unmet. I think in general, just to sort of portray sort of what I've seen is that people have a lot of misinformation about Native American communities. I always get questions or statements like, well, the Indian Health Service is free for Natives, so I don't know what you're complaining about. But I don't think people understand that Indian Health Service is not an insurance company. So as a group, we are the most underfunded people. A lot of our people don't have insurance. And college is not free for us as well. That's the other statement I get. No, we don't get college paid for. But I think what people need to understand is that we are the only politically recognized ethnic group in the United States. We have existing legal agreements and treaties with the US government, and we're not going to give up on that. There's also, working in private practice and in a tribal community, I think gives me sort of a different viewpoint about what healthcare is like in the United States. And I'm happy to see both. But what I see the problem is in access, and what Ben was talking about, economic access, not having insurance, physical access. I think, and I can say in New Mexico that some of our tribal members have to drive 2.5, 3 hours to get specialty care. And a lot of those people don't have transportation. We don't have a train system. We don't have buses. So that's huge. That's a huge problem. Culturally and community appropriate healthcare, we don't have. Specialty healthcare, we don't have. And we also have to remember that Native American groups in this country, we have to think about how one size doesn't fit all. There are more than 500 plus Native American communities, different backgrounds. We're not just one type of Native community. There's a large urban Native population, and there's a lot of travel between reservations and cities in border towns. And it also seems like working on a Native American reservation, we're sort of always in this crisis mode. And we're always catching up. We're always dealing with existing crises. Where I really feel like, and we'll talk about this later, I'm sure, is how to convince our communities to look in depth at the root causes of what's causing these issues, like racism, like the lack of good educational institutions for our kids, and what can be long-term solutions. The real deal breaker, I think, is how do we get our own communities to decide what our clinics and what our healthcare institutions look like. So that's really sort of what I push. The racism issue is huge. I still experience that personally. As one of the few Native American pediatricians in this country, there's less than 200 of us total. When I go in a room and I introduce myself as Dr. Toya, people just see a person and the color. And when I leave, they'll ask me, when is the doctor going to come in? And that's ongoing. And it doesn't, to me, it's one of these things that we have to instill in our communities and our children. It's just one of these things that we have to continue to work on. So that's sort of where I'm coming from. I'm looking forward to helping communities come up with different ways to provide healthcare in more of a public health preventive sense.
Great, thanks, Dr. Toya. Really appreciate those comments. You know, I wanted to ask about if we're thinking about, and this I think I'll post to all of you. You know, we ran a piece today, article by Gary Cunningham that talked about stereotype threat, and you know about the need to really think from a capability standpoint. So if you're thinking from an asset-based approach, from what are the health promoting factors that exist within communities of color that we can lift up. Anybody who wants to jump into that first?
Yeah, I don't mind going first. I think what comes to mind for me, and I'm going to think of my own experiences in the African American community or the Black community, that's faith-based organizations. Absolutely. These institutions have been there since the 1800s, 1700s, actually, 1700s, dating back as early in terms of their organization, 1796. They continue to do amazing work and within communities. In fact, they are, for many communities, the only source of real support that still exists. All of the formal services, the government services have left many urban and rural communities, and what's left are faith-based organizations, specifically churches. The other group that comes to mind is fraternal organizations, fraternities, Black fraternities and sororities, Greek-letter organizations, groups like Masons and Eastern Stars. These are groups that are not oftentimes well known by the majority population, but they are the anchors of these communities. And so I think that we have to really engage them. But I want to say that when we think about engaging on an asset model, it's not for the purpose of exploiting institutions, but supporting them. And they need funding to help them to do their work and to enhance their work.
Thanks. Anybody else want to jump in? Dr. Toya, perhaps?
I think there are some good groups on reservations. The community health representatives, public health groups, they definitely are there. And it's one of the things I think we talked about a little bit in terms of doing work on reservations or in Native communities, is actually mapping the community to find out what groups have been there for a while. And I definitely think that in our communities, those groups have done incredible things, especially during COVID. Those people that work for those organizations have done amazing things. They're the only ones doing work sometimes, taking meals to people, providing care, providing driving for those people who need dialysis. I think that we can build on that. There are not as many of the faith-based organizations like Al was talking about. There are several churches that do good things as well. But I really feel that as we talk more about how we can engage communities, it's really looking at the people who've been there for a while. And most of those people are the Native people who live there.
Great, thanks. Ben, I thought I'd ask you about this. You know, how do you, what would, and you gave a very solid, you know, critique of these are the central organizing principles about why we have structural inequality in our healthcare system, you know, and, you know, we're talking about, only 17% of the economy. So it's a significant chunk. But what would it look like if we democratized the health system and gave communities greater control over their healthcare and their, you know?
Yeah, I think it's a great question, and there's probably no one answer, because part of the point is that different communities have different needs in different contexts, and so how things materialize in different places are going to look different. But the key principle is that I think, as both Elle and Yolanda have been saying, like, we really need much more sort of to put people in their own communities sort of in charge as actors, not as subjects, to really be able to say, here's what our health needs are, and here's how we want our healthcare system to look, and to give people actually some control to hold, you know, private and public actors accountable, and to make decisions, be part of making decisions that affect their lives. So, you know, I think a lot of this stuff is often easiest to start at the local level, and so there's models like participatory budgeting and different sort of models of participatory governance that actually bring people, everyday people, and also community organizations, labor organizations, into sort of co-creating the policies. You know, what does public health policy look like in Alameda County? Or how should the city of Chicago's budget be spent on the neighborhood level? Like, these sorts of models are ways that I think we can bridge sort of what the decisions that get made in government with what's happening with healthcare workers like Dr. Toya, and what the sorts of community institutional partnerships that Elle is working on, find ways to really bring people together in answering that question for themselves, right, in whatever their own local context and local needs are.
Right. You know, I thought I'd ask one more question and move it over to the audience, because there's a ton of questions that have come in. So thank you for your questions. We will get to them. You know, I did think we should, and Ben started the conversation with, you know, appropriately enough, with COVID. Is COVID teaching us anything new about health and healthcare in the US? Or is it more confirming what we already know? And if there are new things, what are they? What are we learning?
I would say that it's confirming what we know. When COVID first started last year and became an international and then a national concern, I was pretty excited to see that tribes here in New Mexico were very quick to respond. And that was in March, because we knew that if it hit our reservations, it would be unforgiving. And it was. You know, we've seen entire families wiped out from COVID. You know, and it's just put a strain on our clinics with the crisis of COVID, so that other public health initiatives have been put to the back seat, like well child checks and vaccines, preventive visits for diabetes and heart disease. So I don't think anything was surprising, but I think it also, what happened was, because the national, our national leadership actually turfed a lot of the COVID activities to the states. And I think the tribes sort of had to sort of rethink about what their connection was with the state government. And I think that was a good thing, because it needed to happen. So, and I was really proud of our tribes that did that. You know, one of the things that came out over the summer was, if you looked at deaths per capita, and if you looked at tribes as a state, the top 7 were tribal governments, reservations, and 4 of them were in New Mexico. So I think that should be a wake-up call to our tribal governments that we are still very fragile, and our health system needs to be looked at. So they did do the right thing. They closed reservation boundaries fairly quickly. But I think what this gives us the opportunity to think about is, if hopefully this doesn't happen again, but how do we change how we respond to pandemics in the future? How are we prepared? And I honestly feel that our voices need to be heard at the national level. We need to have a seat at those tables to understand our communities and to bring that voice back to our individual communities.
Great, thanks. Well, Al, are you trying to speak?
Yeah, sorry, I agree with Dr. Toya on all of those points, that it hasn't taught us anything new. Unfortunately, it's only amplified what we know. I think there are a couple of things I would just add to Dr. Toya, and that is, number one, for me as a public health practitioner, it's really emphasized the need for a global response in future pandemics. We have to have a global coordinated plan. Shutting our borders is not enough. It's inadequate. And so we have to work together with international organizations like the World Health Organization, the United Nations. The only way we're going to get out of this is a coordinated global plan, so that, because, this will, if we don't, what we'll have is a system where the rich, affluent nations will have access to the vaccine and poor nations will not. And that could have devastation across globally. I think the other piece that I want to lift up, and I think all of us have been saying this, is the importance of bottom-up approaches and not just top-down approaches, right, to solving these solutions. Oftentimes, this is about people far, far away making decisions about local communities, when it's really the local communities that really need to lead the way out.
Great, thanks. So this is a question from the audience for Ben. And Ben, if you can't answer this is fine. I was intrigued by the question, so let me put that way. So the question is, do you have any estimates of the economic impact of COVID-19 on communities of color in the United States? Is there any work that your group has done on that?
Yeah, I'm sort of in the process of trying to find out who's been putting out that kind of information. I think, there's numbers on how many millions of jobs have been lost, how many millions of people have lost health insurance. It just sort of, the list goes on, but I'm not off the top of my head sort of able to rattle that off. But I do think it's key both to note that the effects are both really broad. Many, many, many people are hurting. And they're also, especially for people of color, right, they're also very deep, and for poor people more generally. And so I think there's an opportunity both to attend to the specificity of ways in which different communities are being uniquely impacted, and also to try to build, hopefully, more of a sense that, like, here is a perfect illustration of why we need to pull together and have universal systems that are also equitably meeting community needs.
Great, thanks. I would have been surprised if you had an exact number, but I thought it's an important question I hadn't thought about. This is an interesting question too, and I think this is more for Al and maybe Dr. Toya as well. But so here's the question: and it may, as we talk about who is the community, what are your thoughts of working with and building coalitions vis-a-vis community-based participatory research methods? And I would add, or our community-based research participatory methods about working with coalitions, but I'll let you jump into that.
Dr. Toya, you want to go first?
I've heard that term before, and I tell people I'm a recovering epidemiologist. I used to do research back in the day, and I really feel that if I can just maybe rephrase that a little bit, I'm all about coalitions, about working with others. I feel that, I think training and education of Native communities themselves to do this research has to come from them. It has to be initiated by tribal communities to collect, understand why this research needs to happen. Then it's truly collaborative. And that training can happen. I know a lot of Native professionals who have a background in medicine and public health and epidemiology and statistics. And it's happening a little bit. I think it needs to happen more. I think our governing bodies need to really embrace that and take ownership. Otherwise, it's just going to be theoretical. It's going to appear in somebody's padded CV at the university level. It really needs to come from the community. I don't know if that's a good answer enough for you, but I really feel that it's time. It's that time now that the research and data and this collaborative research has to come from the tribes, from our own communities.
Makes sense.
Absolutely. I mean, it's the traditional approaches of community-based participatory research, CBPR, CBPRI, or community-based participatory action. All those are nice, but in some ways they're kind of academic terms. I think that's your point, Steve. It's like, yeah, so in terms of real coalition building, I want to go back to the idea that I mentioned earlier, and that is show me the money, right? If we're going to talk about these issues and these community-driven approaches, it's really about the money. I mean, in tribal communities and Latinx communities and African-American communities. I mean, whoever we build these partnerships and these collaborations with, we have to put our money into community-based approaches that leave something behind in the community, like that create job opportunities, that create opportunities for upward mobility. We can't expect these approaches that have, be it community health workers or promotoras or different models that we're using, wherein we're not even paying people a living wage to be engaged in that work. And so this conversation is about economic development. This is, and Ben talked about this. I mean, it's the upstream impact of COVID-19 is, we're going to live with this for years to come. It's about unemployment. It's about evictions. It's about the death and the loss of long-term wages for families, not to mention the emotional impact. So all of this is going to be devastating. So I think we need right now a real huge infusion of funding into communities globally, not just in the US, but globally. Talking to people in countries where they depend on hospitality industry. Think about people in the Caribbean. They've been devastated. People aren't traveling. They're not going. So it's going to take all of that. But it's community putting that funding. Got to flip that. I think that funding model upside down. Yeah, money never trickles down. It just doesn't. It rarely trickles down. Typically in America, it trickles up. It makes its way, and that means it makes its way outside of that community. It doesn't stay in that community.
Yeah, no, thanks. And I know I've seen like there's $30 billion a year that goes to NIH for research, and the amount that's spent on by the federal government for addressing social determinants of health is far less. Now, there's a question specifically for you that asks you to speak to the experience of Dr. Susan Moore and the less than compassionate care she received, and how that model contributes to racial disparities in healthcare.
Yeah, I mean, I think her death really highlighted in real time, the past year, January 6th, the murder of George Floyd, Breonna Taylor, and the video clip that she shared globally. I think it's those images that have really brought home the reality of race. And I'm going to misquote her, and I think it was something to the effect of, "This is how Black people die or are killed," in her comments. And it talks about the fact that how even as a physician, an African-American female physician, she was subject to what really many would kind of characterize as racism in the healthcare system. And it left me thinking, and many people that I've had discussions with, is like, if this can happen to her, then how can this, how do I stand a chance within the healthcare system as a maybe poor Black or brown person? I'm up against so much. So I think that that's what her death has really served to kind of highlight and resonate within our communities, that this is not a problem of just about people of low literacy. This is an issue that people at every rung of the social ladder are experiencing. Racism doesn't start and stop based on zip codes, area codes, and census tract. It's something that permeates every facet of our community and every individual.
Thanks. So I think this question might be for Dr. Toya, although others you're welcome to comment. So the question is, obviously there not only are there 400,000 people in the United States who have died from COVID, there's tens or hundreds of thousands or maybe even millions more who have long-term conditions resulting from the virus. And how do we prepare for addressing the after effects? So, it's sometimes called, for lack of a better term, long COVID.
I think that's a great question, and that worries me. One of my family members had COVID in July. 6 weeks was in the hospital, 2 weeks in the ICU. Came out of it on oxygen, and there was no support when he went home to the reservation. There's no occupational therapy. There's no physical therapy. Our clinic had pretty much shut down because of the crisis. So there wasn't a support mechanism there, and we talked about this. We knew that we weren't prepared. Right now, I'm worried about what the effect on children is. Right now we're seeing a big burst of COVID positive patients after the holidays, and we knew this was going to happen. And these are mostly pediatric patients. Most of them do fine, but again, we don't have the research or data to understand how this is going to affect children. What are the other secondary effects? Education. All of our kids are missing out on a whole year of academics. How is this going to affect them long term, socially, mentally? I have never prescribed so many antidepressants and antipsychotics in my life as a pediatrician. What that all remains to be sort of fleshed out. We need national guidelines. We need help in collecting that information with our communities. How are our children going to respond to this? Many of our reservation kids don't have internet. Some of them have to drive to the supermarket parking lot to get their internet connection to download their homework, and some of them don't have that access. It's going to be, like Elle said, this is going to take us a long time to understand what the effects are going to be on our communities of color. And again, this is time for our communities themselves to sort of step up to the plate and say, this is what we need. This is the help that we need. So I don't have a good answer, except that I think it has to come down as well, that we need the resources, we need the money, the finances to understand how this is going to affect us. But there has to be as well, coming up from the community level, what do you need? How can I help you? And I think that's one of the questions we had talked about too, is when nonprofits go into these communities, how do you approach a Native community? One is respect, and those questions too, as well as who are you? And tell me about yourself. Tell me about your community. What do you need? How can I augment what services you already have? And that's the fine art of listening. And I don't think in this country in the last couple of years, we've been very good about listening. So that's a huge task I think all of us need to undertake.
Thanks. So let's see, there's a question about, and I think this is a question for Al specifically, but Ben, you may want to comment on this too. And the question was sort of, how do we, given the fact that faith-based organizations are often some of the most important players in communities of color. How is it possible to scale up large-scale funding to those organizations without a faith-based tie? And I think the concern is about establishment issues. So.
And it could be, Steve, about the separation of church and state. It could be those kinds of things as well. I mean, I think that there are ways to do that. There are models out there. Many of the faith-based organizations, and many of them have established community development corporations that have kind of separated themselves from their church. And that's one thing. I want to just kind of also say that the reason why I think this model is promising is because it puts money back into the community. And listening to Dr. Toya and to Ben, it made me think about, like, why do we not trust the community? What is it about us as a society? We're willing to trust large systems and institutions, but we're not willing to trust the community and make those investments at the local level. And oftentimes, not so much more recently, but in the past, I've heard people talk about, we need to make sure we have systems in place to protect and transparency and all these things. And sometimes it's when the money is given to the community, people begin to think about people actually extorting money and stealing money and all of these things. And it's like, but we don't think about that with large institutions and systems, and money is lost every single day just on inefficiencies. So, all of this conversation has just made me think about putting money in the community, either with faith-based organizations, community-based organizations, groups and organizations, tribal communities, where it can have impact. It can be job creation, job generation, and job sustaining, and have an impact. I mean, I've seen some public health projects that have funded summer youth projects and programs as well that have really helped serve to lift up communities and young people.
Great, thanks. Ben, is there anything you want to add from your perspective?
No, I think that was great.
Okay, let's see. There was a question about, what has been the effects the FQHCs have had because of COVID, and assuming there is increased demand for those services, what obstacles are they facing? And if you don't work with FQHCs, I'll have Ben or somebody else jump in.
Yeah, I don't work with them, so you'll probably have to ask Ben or Al.
Okay.
I would defer to Ben. Ben, I think, is closer to FQHCs than I am. We're putting it off on Ben.
Yes. And
that means I don't know.
I don't work directly with federally qualified health centers, but I think that they and other public clinics play a really important role in really being an accessible place that people who don't have a lot of money, and very often, of course, that means communities of color, can get access to care. I think the main problem is that they're underfunded. And so there's great work that they're doing and they're meeting a vital need, and they just don't have the resources, though, we need more of that. And it's just something really skewed when our healthcare system is steering all this money into fancy hospitals that are building whole new wings for luxury rooms, for high-paying patients. And so it's just really out of whack. And so I think what we really need to do is take all the money we're spending, both through taxation and public healthcare dollars and through private healthcare spending, and look at that and say, where is this money needed? Where should we put this? And I think federally qualified health centers are a great institution. An institution, I should add, that were won initially by social movements, right? They weren't just created from up on high by politicians. Like, they were won by people organizing in their own communities and saying, we need our healthcare needs to be met.
Ben, I think that your point is well taken, and that is that, it reminds me at one point in the COVID-19 epidemic, we were still in it. I saw images coming out of India where people were really having to buy a bed in a hospital, right? So, you're describing a very concierge kind of service, healthcare system in America, where if you're wealthy and you can afford it, you can get the best of care. But if you're poor, you get nothing. And I think the other piece around FQHCs is to to think about them as not just providers of healthcare, but also of social services and, employment opportunities. So again, this conversation is making me think about the holistic approach to healthcare delivery in the United States. And I think we're getting there. I mean, many healthcare systems are beginning to ask people questions about social determinants of health. I mean, it's one thing to see people in a hospital. It's another thing to understand that they're leaving the hospital, they're getting on public transportation, or in Dr. Toya's case, they have no transportation back home, right? So it's really important that we look, I think, holistically at this.
Thanks.
In terms of the federally funded healthcare, so the tribal clinic run clinic that I've worked at, I think could qualify as that, because they do have some grants from the feds to do what they do. You're right, Ben, they need more money. One of the things too, as well as I try to convince people, is that tribal communities have to look beyond their own boundaries. They have to look outside the res box, is what I say. And as part of some of these funds that they got from the feds, they had to actually start seeing non-Native American patients. And I can tell you, when that first came out, a lot of the tribal members did not like that, because this was our clinic. It's only for tribal members. And what I tried to push is that we have to be flexible, and we have to look at the fact that we don't live in a bubble. That reservation boundary doesn't just stop people. Well, it does in a way, but we have non-Native people that live in our communities, and why can't we provide healthcare to them as well? So it's sort of looking outside the box in terms of what our healthcare can provide. Up on Jicarilla, there's little communities that are outside of the reservation. We try to provide services to them because they're part of our community. Just because you're not part of the tribe doesn't mean that you're not part of our community. And that's kind of how I feel tribal communities need to look at is this is a whole new century. We have to understand ourselves, our community, but we have to get along with our neighbors, and we have to respect them, and we have to help them. And I think that's a completely different mindset, I think, for a lot of people.
Thanks. So this is another question for you, Dr. Toya. So the question was, you've talked about the importance of listening to communities and having communities sort of say what their needs are rather than the other way around. Are there examples that you're familiar of where that's actually happened, and how's that worked? What's occurred?
I think there's been examples of that. I think there's been attempts to that. There was a question asked about somebody from the University of New Mexico, who I know very well, because we both were at Berkeley at one point, and doing community-based participatory research. And so there's some of that going on. I actually did the clinical work in that community where she was doing her public health research. I heard about it. I didn't see a lot of benefit. So I think those examples exist. There was a researcher, I think, from Johns Hopkins on my reservation a couple of years ago collecting data. I don't know what happened to the data that she was collecting. So I think the attempts are there. I think that tribes really need to sort of take control of who's doing that research and taking that research back, understanding why that research is being done. They need to own it. And then I think when people leave, they have to leave with a good relationship with that community and leave something for them. Like Al was talking about, there has to be some kind of infrastructure where we train people to work in that program, where when they leave, when all of you leave, how is that project, how is that initiative going to stand by on its own? And you can't do that if you don't address involving the community. And so that's why when people talk about research in Native communities, my antennas go up because I have to ask that hard question. Why are you doing this research, and how is it going to benefit our community, and what are you going to leave behind? This belongs to our people. And if it's not going to benefit them, then we don't want it. We don't want it. And that's a whole new, a whole new take on how universities do research, and what happens to that research. And like I was talking about, what was happening with the syphilis experiment. So much research has happened with Native communities that we don't know what happened to the data. It doesn't belong, it gets published and pads somebody's CV. That needs to change. It just, that whole concept of how to do research needs to change.
Thanks. This is a question I think for any of you. Are there recommendations of the specific research or studies that need to be advocated for on behalf of Blacks, Indigenous peoples, and people of color, you know, such as disaggregated data in health and incomes at the local community level? Are there specific things that folks on this call should be advocating for?
I'm an advocate of race data. I mean, I think it's critically important. I had a conversation with someone this week. If we don't collect it, we don't really know the full impact, and at times a disproportionate impact. So I think that the collection of that data and any other information that will help us to really kind of drill down to the local level, even gender data, is just so very important.
Great. I'll ask one last, go ahead,
Steve,
and then
Steve, hold on. I wanted to add that to Al. For me personally, what my work is focused on is working with children, specifically pregnant women, following them through pregnancy, how diet, alcohol, drugs affect them, how stress affects them, and then following those children up to age 3 to 4 to 5. And I'm a huge believer that we need to create that healthy generation of children. Then they can survive and do well in elementary school, high school, and go on to college. So that's my big push, is to get more information about how those toxins affect children in the womb all the way up to age 5.
Thanks, that's really important. So one last question, and then we're almost at the hour. But what is your hope, and I'll give you each like a minute or so on this. What is your hope for the new administration? What would be your top policy ask? Whoever wants to go first, and you each get a shot.
All right, I'll jump in. I've got my list here. First of all, mandated racial data, number one. Number two, a national youth jobs program. I've benefited from that when I was many years ago, all year round, and certainly for the summer. Number three, a coordinated federal response to COVID-19, which is actually number one. Support for health equity, and as a graduate of a historically Black college and university, increased support for minority serving institutions.
Okay, well, that's more than one, but thanks, Al.
I had a list.
You were prepared. Ben.
I guess an overall thing I would hope is that the administration would really push towards guaranteeing healthcare rather than the private commodity, treating it as a public good. So investing in Medicaid, protecting against cuts, moving towards really healthcare as a public good. And the only other thing I'd add is that not for us just to look to the administration as a solver of our problems, but actually they're only going to do this stuff if we push them. And so I think I'm looking to all of us to make the change.
Okay, and Dr. Toya, you get the last word. I'm not leaving you out.
I think Alan sort of talked everything that I was on my list as well. Immediately, I think we need vaccines for all Native Americans and high-risk populations. That just has to be our focus this year. And then we need the increased surveillance on short and long-term effects of COVID. Financial need for our Indian Health Service and tribally run clinics is huge, and with a focus on prevention. And then the last thing is that we have a seat at the national level. We need a seat at the table that will give us our voice to decide what happens to our communities.
Okay, well, with that, there's a ton more questions. We got to as many as we could. I want to thank our great panelist, Ben Palmquist from Partners for Dignity and Rights, Al Richmond from Community Campus Partnerships for Health, and Dr. Yolandra Toya. Thanks to all of you for your questions as well. And please do complete the survey after the event. And we will be back with a webinar in Thursday of February. So look forward to that. So thanks again to everyone.